So the nervous system is made up of the central nervous system and the peripheral nervous system. So under the central nervous system, you have the brain, and then you have the spinal cord. Then the peripheral nervous system is where we have the nerves, which are the motor nerves and the sensory nerves. So the somatic nerves, the motor nerves are the somatic nerves, and then we have the autonomic, okay, which is made up of sympathetic and parasympathetic, which is your fight or flight. Okay, so what's the purpose of this? So again, the central nervous system has the brain and the spinal cord. Okay, so it's responsible for controlling voluntary and involuntary movement. Okay, and it's also a command center. Then for the peripheral nervous system, where we have the nerves, that's the somatic nerves and the autonomic, we have the motor nerves and the sensory nerves, then we have somatic, autonomic, then under autonomic, it will be your fight or flight response, which is your sympathetic and parasympathetic. And here the main thing is it maintains homeostasis. So following up on still the nervous system, yeah, so we'll focus now on the central nervous system, which has the brain and the spinal cord. So to kick off the lesson, we'll start with the brain. Okay, so what are some of the functions of the brain? The brain helps with conscious awareness. Okay, it helps with coordination and balance. It helps with reflexes, pain processing, language and communication. It also helps to shape personality and identity. So those are all the functions of the brain. Adaptations, it helps the individual to adapt to new changes. Again, consciousness and awareness, coordination and balance. These are all the functions of the brain. Reflexes, pain processing, language and communication, helps to shape the personality and identity. And then of course adaptation, how we adapt to new changes or new surroundings or even to stressors. So now the different parts of the brain. Okay, so we have I'll start with the parietal lobe of the brain. Okay, so the parietal lobe of the brain has to do with sensation and language, perception and attention. Okay, so the parietal lobe, sensation, language, perception and attention. Then the frontal lobe has to do with problem solving, judgment, thinking and behavior. So if you have a patient where they have issues with the frontal lobe, then their judgment is not going to be accurate. Okay, those are patients that they make bad judgments. If you say sit here, they might want to move. So if such a patient came back from a procedure with a frontal lobe that has issue, then they're not thinking straight. So for example, you leave them to sit in a particular position, they might get up and fall, right? So because their frontal lobe is kind of messed up, their problem solving and concentration, thinking and behaviors all has to do with the frontal lobe. That's what it does. Then we have the temporal lobe, which has to do with hearing, language and memory. So if the temporal lobe has issues, then the patient will have hearing difficulties. These are, again, some of the patients that will end up with hearing aids and stuff like that. Then language too. Stroke can cause a patient's temporal lobe to be messed up, so they'll have difficulties in their speech, in their speaking. Then memory-wise, they're forgetful. You tell them something now, they forget later. So that's your temporal lobe right there. Then also we have the occipital lobe. The occipital lobe controls the vision. So these are patients now, you see they start having vision issues because their occipital lobe of the brain is not functioning right. It controls vision and perception. So the way they perceive things is different, okay, because the occipital lobe is messed up. Then, so we've talked about the parietal lobe, which controls sensation, language and perception and attention. Sensation has to do with touch. So if the parietal lobe is messed up, then that's a patient where, for example, you can say diabetic neuropathy, which they don't have sensation on the extremity. They have no sensation at all. So you can actually have a patient where they put themselves in warm water and they don't feel it, and then they injure themselves because the parietal lobe has issues. So again, parietal lobe has to do with sensation, language, perception, attention. Then the frontal lobe, again, I said it was problem solving, concentration, thinking, okay, judgment, okay. Then temporal lobe, we will say it was the hearing and memory. Then occipital lobe, of course, the speech and perception. Then so those are the different lobes of the brain, okay. So now let's move to the brain stem, okay. So the brain stem now, the brain stem has to do with consciousness, okay. This is where breathing and heart rate, okay. So if you think of it, the brain stem, I look at it like a powerhouse, okay. Or it helps with unconscious actions, okay. So for example, you cannot tell yourself that, oh, I want to breathe right now, oh, I want my heart to beat. So that's all responsibility of the brainstem right there, okay. Then from the brainstem, I want us to talk about another part of the brain called cerebellum, which has to do with posture and balance, okay. So if you see a patient, like for patients that have Parkinson's disease, they have shuffling gait, they have balance issue, it means that's the part of their brain that is affected with Parkinson, right? Because their posture and their balance is not stable. Then let's switch now to sensory and motor areas of the brain. Because remember when we talked about the nervous system in general, we said the nervous system had the central nervous system and the peripheral nervous system. Under the peripheral nervous system, we talked about the motor nerves and the sensory nerves. So what are these parts of the brain now? The motor nerves and the sensory nerves of the brain, all it does is that motor activity, right? Voluntary muscle movement, okay, and sensation. We talked about the sensory area of the brain is about temperature, pressure, and pain. Okay, so that just gives us an overview of the brain and what it does, the different parts of the brain, the lobes of the brain, and of course we've talked about the brainstem. I call it the powerhouse because it controls the involuntary automatic responses. Then of course then the cerebellum, that has to do with movement and coordination and balance and posture. Then of course now we're looking at the motor areas of the brain, the sensory areas, which has to do with sensation, pain, temperature, and pressure. Then finally, we're looking at the motor area that has to do with your muscles and your voluntary muscles. So that will end it. You have most of this information is in your PowerPoint. Encourage you to look at it, and that will help you in your exams. Okay, so I want us to go over stroke, but before we go over stroke, I want us to look at the nervous system in a whole. So the nervous system has is divided into the central nervous system and the peripheral nervous system. Okay, so we'll focus today on the central nervous system because stroke is one of the disruptions of the central nervous system. Okay, so the central nervous system is made up of the brain and the spinal cord. And then stroke literally is an attack on the brain. So you see how for heart attack is an attack on the heart, for stroke is an attack on the brain. So another name for stroke, they can call it CVA, cerebrovascular disease, or CVA or stroke is the same thing. So with stroke, we have two types of stroke. It can be ischemic stroke or hemorrhagic stroke. Okay, so we start with ischemic stroke. Literally just means that there's a blood clot. Okay, there's a blood clot has formed around the artery. or around the wall of the artery, there's a blood clot that has formed around that area. And in another terms, they'll call it embolism, okay? So if you hear the word embolism, it's just saying that it's a blood clot. And again, this blood clot, it can be like, it's plaque that has built up, blocking flow of blood in the brain. So so that's ischemic stroke. Then hemorrhagic stroke, hemorrhage, bleeding, right? It's a stroke that is caused by a rupture of an artery. And you see it, sometimes you'll be aneurysm, which just means that the weakening of the artery. And also for hemorrhagic stroke, it can be as a result of uncontrolled blood pressure. So sometimes if you see those scenarios where the blood pressure is relatively high, uncontrolled blood pressure can lead to bleed in the brain. Okay, and of course the collection of that blood in the brain now will lead to ischemia, or maybe increased intracranial pressure and all of that. But mainly, just remember that for stroke, you have ischemic stroke and hemorrhagic stroke. Ischemic stroke is just saying that there's a blockage somewhere in blood flow. Hemorrhagic stroke is just letting us know that the blood vessel has ruptured. And then what are some of the risk factors of this stroke? It can be anywhere from family history to hypertension to diet. Okay, so uncontrolled hypertension, again, we see that which is relating to hemorrhagic stroke. Okay, family history, yes. Obesity, diabetes, stress, and sometimes oral contraceptives can be a risk factor for stroke. Okay, so now we have risk factors that are modifiable, and modifiable just means that we can do something about it. Then we have risk factors that are non-modifiable. There's nothing we can do about it, like genetics. There's nothing you can do. If you have a family history of stroke, that's genetics, so we can't modify that. But for lifestyle, we can modify lifestyle. If the stroke, the risk factor is as a result of diet, we can modify diet. If it's as a result of high cholesterol, then we can, of course, we can modify that. Or diabetes, we can do lifestyle changes. Oral contraceptives. Sometimes you get questions where a patient is on oral contraceptives and the exam is trying to figure out if you know that that could be a risk factor for stroke. So just FYI, especially for NCLEX, oral contraceptives can be a risk factor for stroke. Okay, so now with the two different kinds of stroke that we've established here, and then we've looked at the risk factors. Now let's look at the signs and symptoms of stroke. The acronym FAST, that just helps us with that. First of all, you look at the face, facial droop, right? It's like one side of the face is slided, just like that. Then arm weakness. So you ask the patient to pick up their arm and one side is weak, and sometimes the patient will complain of numbness and tingling sensation to their extremities. There's slurred speech. Patient is about to talk, their speech is slurred. Then of course time. If you see here, I say time is brain. Every second counts when it comes to stroke, every second counts. Because we want to catch the stroke in a place that we can reverse it so the damage is not too much. And then there's another symptom that creep up on patients is terrible headache. Why would a patient have terrible headache in stroke? One, because we say hemorrhagic stroke has to do with uncontrolled blood pressure, right? So you see, if somebody's blood pressure is uncontrolled, they can have that terrible headache, and maybe that's all that they will show as a sign. So that's what we have there. So FAST, you use that as an acronym. Then another key thing to remember about stroke is diagnosis, okay? So if you see any of these signs on a patient, the first thing is like you want to determine if it's a stroke and what kind of stroke it is, because based on the kind of stroke, each stroke has a treatment pathway, okay? And based on the CT scan, we can tell if it's a hemorrhagic stroke or an ischemic stroke. So CT is critical, important for us to know when it comes to stroke. So we'll do a CT scan for the patient, okay, and then we determine what kind of stroke this is. If the stroke if the CT shows that it's an ischemic stroke, then what we'll do is that we have a time frame. It's 3 to 4.5 hours for an ischemic, for the first onset of symptoms, for us to give TPA. TPA is a treatment for stroke, tissue plasminogen activator. TPA, tissue plasminogen activator. So if it's an ischemic stroke, then we have that 3 to 4.5 hours to give them that TPA, which TPA is a blood buster. We just remove the clot or all of that. It's a clot buster. Okay, so and it would help to dissolve the clot, and yeah, that would be the treatment pathway for ischemic stroke. But then that time factor plays a lot. Yeah, blood buster, it plays a lot. Or they can do a thrombectomy, which will just removal of the if ischemic stroke, they can also do a thrombectomy just to remove the clot. And then after they've either if they use a TPA or thrombectomy, then we can now manage with medication, which are your anticoagulants or antiplatelet. This will help to it's just used for preventing more clots from forming. Yes, just preventing more. But initially, the goal for treatment will be the TPA, and then just remember that time frame. Because sometimes they give questions and they want to figure out if you know that it's too late for TPA. Once it passes that time frame, then it's probably too late, then something else, they won't do it. Okay, then now when you're giving TPA as a nurse, there are things that you have to watch for. Okay, avoid unnecessary injections, because TPA is a clot buster. It already puts a patient at risk for bleeding, right? So if they don't need unnecessary injections, we avoid it. Anything that will cause bleeding, we want to avoid that. We want to prevent injury by bed rest is essential. When they're on TPA, we want to keep them on bed rest, because think of it, if the patient is on TPA, and initially these patients will be in the ICU, right? If a patient is on TPA and they fall, guess what? They probably have a bleed in the brain. So we want to make sure we're preventing all kind of injury, and then we're checking the site for bleeding, just because now they are prone to bleeding. Okay. So that's it for ischemic stroke. Then for hemorrhagic stroke, as we said earlier, uncontrolled blood pressure will cause hemorrhagic stroke. So what will be your treatment for that? We want to manage the blood pressure. But then your physician will give you a perimeter where you can stay around. That blood pressure should stay within a certain perimeter. So we'll look for that in those orders. Then of course surgery can be done to repair the ruptured vessel. Okay, so now we've seen ischemic stroke, we've seen hemorrhagic stroke, we've looked at signs and symptoms, and then we've looked at diagnosis. We want to do a CT scan to know what kind of stroke we're dealing with, because you don't want to give a blood buster to somebody that has hemorrhagic stroke. That would be terrible. Yes, you only give it to ischemic stroke. So now we go to our nursing considerations. What kind of, because this patient already has a stroke, whether it's an ischemic stroke or a hemorrhagic stroke, there are some things that we have to do. So feeding wise, what do you think how would the head of the bed look like for a patient with a stroke? Or what kind of feeding? Any idea? How will we feed them?
On the non-affected side.
Yes, okay, so say if the stroke affected the arms or whatever, the left side or the right side, yes, but then if it affects the speech or swallowing reflex, so this patient will no longer be able to eat normal food, right? Mm-hmm. So puree diet. So that's why we're checking at that swallow. Mm-hmm. So you can do a bedside swallow test. And how would you do a bedside swallow test? You give them water to drink, and then you check and see if when they swallow it, they cough. So if they're coughing, then that tells you that they have issues with their swallowing. So now we'll consult speech therapies, where we'll find a diet that is appropriate for the patient, and most of the time it will be puree diet. Okay, so we want to assist them with safe feeding. Do not feed until gag reflex has come back. Make sure they have gag reflex before you're feeding, because we're trying to reduce the chances of aspiration. And then setting up their room, we want to always put a suction at bedside. In case they aspirate, we can easily suction them. Okay, so medication wise, if they're having PO meds, we want to crush, put in applesauce. But then when you're crushing meds, make sure the meds that you're crushing are meds that are supposed to be crushed. So any idea what kind of meds we don't crush? Do you know?
Coded medicine.
Coded medicine and squad tablet. We don't want to crush any of those. So if you get a patient with coded medicine and squad tablet, what I'll tell you is that call the doctor to switch it to liquid or in any other form, because those particular ones we don't want to crush them. Okay, so positioning the client's head of bed, of course, using pillows to support the affected sides. We want to do that. So for communication, say this patient lost their speech during the stroke. So now you have to be aware that there are some certain communication techniques that you can use. Of course, what I use mostly is like a board. They can write on it, you write back, and so that's one of the easiest methods of communication. Or now you have some patients that they have their tablets, so they just communicate based on those tablets and stuff like that. So that could be another form of communication with patients with stroke. And then so we assist them with communication skills. So because sometimes if you have your SADA questions, you have those communication skills. So that just tells you that the patient lost their speech during the stroke. So we're assisting them with communication skills and all of that. Then we want to do range of motion. Say their left side is weak, we want to do range of motion that we turn them every hour, every 2 hours. We want to use pillows, to help with that circulation and all of that. Then of course you'll be working with the physical therapy, because you want to know how to transfer this patient from one position to another. And then we can use SCDs for their legs, okay, just to prevent more clots, because once a patient has had a stroke, they can have another stroke again. It's so easy for them just to keep having stroke back to back, and all of that. So if you're talking, especially for somebody that has lost their speech, right? If you're talking to them, just be slow, because it's like they have the words inside, but then they're struggling to bring it out. They keep struggling to bring it out. So sometimes we are very patient with these patients. We give them time to bring out their words, because they easily get frustrated. Because it's like you have so much in your head, but then you don't know how to relate it. That can cause a lot of frustration. Yeah. So again, as we're looking at the nervous system, stroke is under central nervous system, and it's one of the issues of central nervous system. So now, so our main thing is that we're preventing complications, aspiration pneumonia. So make sure that head of bed is in the right position, especially after they've eaten, but because if not, they can easily aspirate. And then as you're setting up those rooms, make sure they have a suction ready. So if they should aspirate, we go ahead and use that right away. So now we come to our question here. A patient arrives the hospital within a recommended time frame for thrombolytic therapy after experiencing an ischemic stroke. Which information is essential for the nurse to obtain before administering thrombolytic therapy? One, the patient's insurance information. B is the time the patient was last known without stroke symptoms. C, the patient's weight and height. And D, the patient's family history of stroke. So again, when you're looking at these questions, I want you to think safe, okay? What is the safest thing for this patient at this point? You can have more than 2 right answers, but what is the safest thing for a patient that is arriving the hospital with symptoms of stroke. What would be the safest thing for this patient?
I would say the height and weight.
Okay, so if you just do the height and weight and leave this patient alone, are they going to be fine?
No.
No. Okay. So think of something that, based on our short lecture on stroke,
The family history.
okay, family history just tells us that they have a family history. So remember I talked about time frame. So we need to know what kind of stroke we're treating. So first of all, we start with the question. We look what's the central thing of the question. You already told us there was ischemic stroke. Then your second thinking is like, with ischemic stroke, I have a time frame for medication, which is a TPA. So use that information to see if you can figure out the right answer. B. You see how the right answer came about? Yes. So the biggest thing for stroke is, when was the last time that they were normal? So if you have a patient that comes in, they say we're suspecting stroke, or even if you're taking care of, if you're in the hospital or in the nursing home, you're taking care of a patient that you're suspecting that they have a stroke. Your biggest thing will be like, if EMT comes to the nursing home to pick them up, the biggest thing will be like, when was the last time that they were normal? Because they're trying to figure out if they qualify for TPA. Yes. So they test that a lot. So that's the biggest thing, their last normal. If it's at home, say there's a family member that started showing symptoms of stroke, they bring them to the hospital. Whatever nurse is receiving that patient, the first thing they're asking is like, when was the last time that they were normal? Because they're trying to determine if they qualify for clotbuster TPA. Yes. So that's how your answer became B.
And see, the reason I picked weight and height is because I was zeroing in on the part where, what is it important for you to do before you give them the medicine? I'm thinking that you gotta know their height and weight to know how much medicine to give.
Yes, that is when you have already established the kind of medicine that you're giving. So at this point, weight and height is good. Okay, so now that we know that we will give TPA, and then we'll now take the weight and the height. Yes, so that's why they say you narrow down to 2 answers. One is the best. So your best answer is always going to relate to what is the safest thing I can do for my patient. So that's how your best answer is going to relate to most of the time.
And initially I thought B, and I talked myself out.
No, your first instinct
I do
most of the time is the right thing. Your first instinct is the right thing.
My first initial thought is B, and then I'm like, wait a minute. Right before administering the medicine, they probably want to know the height and weight to know how much medicine to give them.
Exactly.
So
But then the first thing is like, what medicine are we giving?
Exactly.
Because if we do a CT, and then CT too is priority for stroke. Why? Because CT is going to tell us if it's ischemic stroke or it's hemorrhagic stroke. So if it's ischemic stroke, then we do TPA. If it's hemorrhagic stroke, then we are now in a different place. Okay, yeah, because they're already bleeding. TPA is going to be contraindicated. If you give TPA to somebody with hemorrhagic stroke, probably just kill them, because they're just going to bleed to death. So that's why it's essential for us to know that. So I think that concludes that. I think we can follow up with now medications for anticoagulants and antiplatelets.